I cannot record it. Yeah? Okay.
I just started recording.
Okay. Excellent. So thank you very much for accepting this interview. Thank you for the time. And during our previous discussions, you said that your platform, you're running a platform that it can help. It can help to lower COVID morbidity and mortality by restoring T-cell aging. Can you explain a little bit how this can happen, or how do you use this platform? You know, how do you use it with patients, or how do you design this, or all of this for those who does not have never even heard about this, that they are not aware that such platform exists. For me, it was the first time that I heard about it. I didn't even know that such platform exists, and I do not know how you use it.
Well, let me first say that we don't know what the platform will do. We know what we think it'll do, and we know some supportive data. But for example, it's certainly very possible, and again, there's supportive data. It's very possible that it may be able to lower COVID mortality, particularly for elderly people, to that of the COVID mortality for a 20-year-old, for example, which is not zero, but it's lower than for example, a 70-year-old. So it may be able to lower that. And the data suggests that we may be able to do that, but we've never done it before. Now, would you like to know more about the platform generally?
Yes. And T-cell aging, by resetting T-cell aging. How resetting T-cell aging can help, can reduce mortality or morbidity of COVID patients, or in general, the elderly?
Well, the platform itself doesn't simply address T cells; it addresses cells in general. And as you know, if I went back to about 100 years ago, we used to think that cells didn't age, but the body did. It was something about multicellular organisms. And that was really disproven nicely by Dr. Leonard Hayflick in about 1961. And what he showed is that cells have a limited number of divisions. They have a finite number of divisions, depending on the species and the cell type. And it wasn't clear what the clock was for that limited number of divisions, but it was clear that the cells age over time, and that it ultimately was likely to be responsible for what you and I see as aging in us and in other animals. And it wasn't until the mid-90s that we began to pin down that clock as the telomere, and that point was proven definitively really in 1998, when we showed that if you could reset the telomeric clock in human cells in the laboratory, you could reset the aging process, the cellular aging process. And again, within limits technically, but it was a nice demonstration. And the same thing was shown 2 years later with human tissues in the laboratory, showing that if you, for example, take human skin cells, you can take older human skin cells, and if you reset telomere lengths, you can grow young human skin from them. The same is true of bone and vascular tissues. So in principle, what the model suggested then, and has gone on in a much more definitive way to suggest since, is that all aging and age-related diseases are related to cell aging, and that cell aging is not caused by telomere shortening, but it's modulated by it. That's sort of the conductor of the orchestra in a sense. And again, all of the data suggested that if we could reset the telomere length, we could reset the pattern of gene expression, and so that what were older cells will act more like young, normal, healthy cells. Then that was shown nicely in an animal study in 2011 out of Harvard. And then 2012, it was shown by Maria Blasco in Madrid. And she did it using a method that I could use clinically in patients. So the overall platform is to be able to take a human telomerase gene and put it into cells to reset telomere length, to reset cell aging, to restore normal function, and thereby prevent and cure age-related diseases. To the extent to which that's true, we should be able to prevent and cure things like age-related dementias, Alzheimer's, Parkinson's, and so on, or age-related cardiovascular disease. Now, with regard to COVID, there's been first there was certainly a lot of theoretical interest in the idea that T cells, and for that matter, B cells, but largely T cells, were less functional. We know this is true in older people, but the presumption was that was part of why older people tended to have a higher mortality rate from COVID. And again, there's been some data that suggests that that also is true. The question is, if we intervene, for example, if I use an adeno-associated virus and a human telomerase gene to reset your T cells, could I reset their aging to that of a younger cell function? And again, there's some data to suggest that that's probably true, but no one's done it yet.
Okay, and where do you do that? Do you need, does a patient need to go to a clinic? Or where do you do all of that, you know?
Currently, you can't. It is remarkably easy to talk about it, but the technical details, as you might guess, are actually very difficult. Example, you need to be able to create the adeno-associated virus with the human telomerase gene in it, and you need to be able to get a high quality and a high quantity of that. You also need to have a good promoter, and there's some question about what is the best promoter to make the cell actually take the human telomerase gene and produce telomerase. Also, the current adeno-associated viruses and other viral vectors we use are by no means optimal. By analogy, I would say that the analogy would be this. In 1903, the Wright brothers flew the first powered air flight for, I think, 12 seconds. Wasn't very long. And in principle, they actually proved you could have powered flight rather than hot air balloons. And it was the French, by the way, 3 to 5 years later, who began to actually agree with it. Most people in the world didn't believe it for a number of years. But in principle, they proved it could be done. But their flight was, while it proved the principle, it was an unremarkable airplane. It was certainly not a Fokker. It was not a Cessna. It was certainly not an Airbus 380. It proved the principle, but it was not a very effective plane. That's where we are with regard to AAV use in a number of diseases, not simply what we're talking about, but gene therapy in general. The current viral vectors we have are kind of equivalent to the Wright brothers. They fly, but they're not going to take 100 people and take them across the Atlantic. They're just not that good yet. We'll get better.
Okay. And do you think it can work for preventing the dementia and Parkinson?
I think it can do better than that. I think we can demonstrate that we can cure the dementias, including Parkinson's and Alzheimer's.
Are there people who are cured by this method?
Sorry, what's the question?
Are there people who are there patients who are cured by using this platform?
Not yet.
Not yet?
No,
Okay.
that's why I say I think we can do it, but we need to actually demonstrate it in carefully controlled trials.
Mm-hmm. And how long does it take?
Well, both theoretical considerations and the animal data suggest that if I were to inject somebody with moderate Alzheimer's right now, we can probably turn around some of the cognitive decline within a matter of months. That remains to be seen.
Okay, and do you have any plan, any program, any timeline for launching this?
We do. I think our first human trials are likely to begin in approximately 2 years.
Okay. Okay, it will begin in 2 years, or it will take 2 years to have?
I think it'll take us 3 years before we have firm data, but it'll begin in about 2 years. And by the time we're finished with 3 years, we anticipate having good data.
Okay, great. That's a good news. Also, you have mentioned, from the articles that I sent you that there are many people, many experts that they do not understand the process of aging. That's why they said a lot of things, as far as I understood what you wanted to say. And even those who should understand it, they misunderstand it. Is it because the process of aging is very difficult to be understood, or it's because they are not really doing their job?
Well, I think it's partly what you just said. It's partly that the process is remarkably complex, but there's also a certain amount of sort of conceptual inertia involved in being a human being. We tend to assume that we understand things that we don't. And the example I gave in one of my talks was the Shakespeare's Macbeth in the beginning, where Macbeth is told, for example, that he can't be conquered until Great Birnam Wood comes to Dunsinane Hill. And both Macbeth and the audience, the first time they see that play, assumes that that means he can't be conquered, because clearly the entire forest can't come to Dunsinane Hill, but it does. But we tend to make that sort of assumption. Lord Kelvin made that same assumption in 1895. He knew about weight, knew about air pressure, he knew a great deal about gravity, but he knew nothing about aerodynamics, and he made the statement that they will never have heavier than air flight. It was an assumption he made, and it seemed reasonable. Again, it was sort of a conceptual inertia. We make the same mistake with regard to aging. And I first ran into this about 50 years ago when I was a graduate student at Stanford. I guess 45 years ago. And I would talk to people about aging. If I talked to people about the development of the nervous system, people found it very impressive, and they were very impressed by the complexity of it. And it is remarkably complicated. But if I talked about aging, people tended to shrug and say, well, that just happens. You get older and things fall apart. And that sort of blasé attitude to me is a sign of intellectual laziness. It usually implies there's more going on that you're not simply willing to open your mind to and look at. And I find that when you really look carefully at aging, rather than focus just on the biomarkers of it, if you ask yourself why it's really happening, it gets more and more complicated. And that's true whether you're looking at gray hair, osteoarthritis, cardiovascular disease, or the dementias. Example in dementia, there has been an assumption for about 111 years now that, that Alzheimer's was simply a result of beta amyloid plaque. And more recently, we began to add new wrinkles to that, like tau tangles, mitochondrial dysfunction, microglial activation, and inflammation, it goes on and on. But those are secondary phenomena. To say that beta amyloid or tau tangles cause Alzheimer's is sort of like saying COVID is caused by fever, aches and pains, loss of sense of smell and taste. No, those are quite valid measures, but they're not COVID. They are outcomes of COVID. The COVID is an infection. Mm-hmm. And I think that's what we do with aging. We look at the biomarkers and the outcomes rather than look down behind it and ask ourselves, why does beta amyloid plaque occur? Why do microaggregates occur? Why is it that some people with a gene have an increased risk and other people with the same gene don't seem to get it? Why is it that head trauma increases your risk? Why is it that exposure to some toxins, for example, paraquat in the case of Parkinson's, increases your risk? Why does that happen? Those are complexities that people tend to ignore. Mm-hmm. And in consequence, we don't make clinical progress.
Mm-hmm. So what, in simple words, if you want to define the aging, what's aging for those who do not know?
Well, most people, if they were asked what it is, would say it's just a matter of entropy. Again, things fall apart. The problem with that is that different species fall apart at different rates. Progeric children fall apart at faster than we do. And there are even some cells that never age whatsoever. And the classic example is, every cell in your body derives from a fertilized ovum. And most of that you got from your mother, who got it from her mother, who got it from her mother. In each case, it was a couple of decades older. And you can trace that unbroken line of cells back for 4.5 billion years on this planet. And that line of cells showed no aging whatsoever for 4.5 billion years. And yet it ages over a matter of decades in you and I. So you can't simply say it's entropy without explaining why entropy works at different rates and sometimes not at all. And the answer is, it's not just entropy, it's entropy balanced against maintenance. Here I am in my home, and this home was built about 1836. And the reason it has survived so long and hopefully will continue to survive, it's not because it was just well built. There's entropy. It's continually aging and weathering. It's because it was maintained. And if you do not maintain a home, it falls apart. But the same is true in everything biologically too. If you look at the maintenance processes in young cells, what you find, or in germ cell line going back 4.5 billion years, or in your mitochondrial line going back 1.7 billion years, you find that maintenance has effectively balanced entropy. That is, yes, there's damage to mitochondria, yes, it's repaired. Yes, there's damage to the cell, yes, it's repaired. But if you look at cells, somatic cells in your body right now, you find that the rate of maintenance slows with age. Example, in Alzheimer's disease, if we look at the turnover rate for beta amyloid molecules, you find it in young cells is very rapid. That is, you make beta amyloid, you break it down. You make it, you break it down. It's continually being recycled, whether it's damaged or not. It's continually being recycled regardless of damage. But as we age, the rate of recycling of those beta amyloid molecules goes down. That is, you make it less frequently, you break it down less frequently. So it sits around a little longer, so it's more likely to denature, cross-link, grab together, form microaggregates. And the rate at which it does that depends on your genes and a lot of other things. But the overall process is that aging cells, for example, the glial cells and the neurons in your brain, are slower in their rate of maintenance. And so entropy begins to win. So aging is not simply entropy. It's entropy in the face of repair, constant repair, continual repair. And that's what slows down with age. And that's why you and I end up with age-related disease.
Mm-hmm. Okay, thank you very much. So another question I have asked you about the using of artificial intelligence to develop a new treatment for COVID. You said that it is not, it's garbage in, garbage
Garbage in, garbage out. It's an old an IT phrase, GIGO, garbage in, garbage out. Yes, if you ask the computer a dumb question, you'll get a dumb answer. And artificial intelligence has enormous potential, but we have to remember what it can do and what it can't do. So, for example, say again, Lord Kelvin in 1895 had access to artificial intelligence and he'd given it everything he knew about air pressure and weight and so on. The computer would have said, powered flight's impossible, heavier than air aircraft are impossible, because he was starting with an assumption and building it into his questions, his data. And another example would be if you and I went back 500 years ago to France, for example, and we knew a smallpox epidemic was coming, and we were to ask all the local herbalists, what can we do about treating smallpox or preventing smallpox? And then we gave them quantum mechanics, quantum mechanical computers, quantum computing, artificial intelligence, massive data crunching. If we gave an access to precision medicine, they would ask the wrong question. They would be asking what herb, what root, what leaf should we use? And those would be good questions. But artificial intelligence can answer those questions, but it couldn't then say, you know, I think there's such a thing as an invisible microbe that's causing this, a little virus that's causing this. So the problem with AI is if you ask the right questions, you will get probably as good answer as you can get. But if you ask the wrong questions or start with the wrong assumptions, the computer can't solve that for you. It's not going to make that leap. And again, back 500 years ago, it's not going to say your whole idea about small molecular approach in herbal medicine is not going to help smallpox. What you need is a vaccination. AI won't do that. We need somebody to step back and go, maybe we're wrong about all this. I wonder if there are invisible little microscopic creatures causing this, which of course was thought to be the height of lunacy 500 years ago. So.
Yeah, it's really complicated. Of course, I think that those who are using or trying to use artificial intelligence for drug development, they do not claim that the computer will solve the problem. They are just using artificial intelligence to have faster access to the data processing. I think that that's their objective.
Well, it might solve certain problems. So, for example, say that I have 1,000 possible small molecules. And I know that some of them work fairly well for disease and some of them don't. And I asked the AI essentially to go through them and not only identify which are better than others, but predict ahead of time based on structural considerations, what will be the best molecule that we haven't identified yet. Okay. That's a reasonable question to sort of ask. But it cannot say you shouldn't be looking at molecules at all. Mm-hmm. That's the wrong question. And that's kind of where we are. So AI is enormously beneficial. If what we're looking at is trying to identify the best vaccine, and we already have a great deal of data about it and can predict what might be better, AI is worth thinking about. But if in fact the right answer had nothing to do with vaccine, but we're asking the wrong question, AI is not going to correct your misconception.
Sure. And just a second, I turn on the light. It's getting dark here. Just a second. Sorry about this. Yes, I was, yes, about the vaccine. Yesterday, we said that the Pfizer has a lot of positive results. It says that it's 90%, 90% positive results for COVID vaccine, but still they say that it will take months and months before it can be accessible. So do you think that they have used artificial intelligence? Did they really use everything that could facilitate and accelerate the process of a vaccine discovery, or it's just commercial, you know, because people are also afraid that vaccine companies, you know, they're just thinking about to get richer and richer by a COVID-19, you know, vaccine. So a lot of companies, even small startups everywhere, they have launched into COVID vaccine adventure. I wonder if all of them, you know, they have non-commercial goals. So people are really reluctant and, you know, pessimist about the COVID vaccine and upcoming COVID vaccine. Do you think that it can be sure, it is efficient, it is risk-free? And the big question is it efficient for the elderly, for the people over the age of 65? That's the big question.
I think you've just asked a half a dozen questions all at once. As to that question about sort of the cupidity of drug manufacturers. Drug manufacturers are like anybody else. Some of them are terrified they and their families will die, and they would do anything to get a good vaccine. Some of them have a narrower commercial focus. Most drug companies probably fairly honest and reasonable. And again, they're very human about these things, particularly since a lot of governments have been funding the research, although not for Pfizer. Pfizer's been funding its own. So there's no simple answer to that. Some drug companies and some individuals are heroes and deserve to be treated with enormous respect, and others, as I say, have somewhat less pleasant motives.
How we can identify them?
I don't think you always can.
That's the big problem.
And if I am an evil person, the last thing I want to think is that you'll identify me as that. But seriously, people are people. And I do not think there's a conspiracy out there, because conspiracies usually don't last very long because people frankly aren't bright enough and secretive enough to have a conspiracy usually. But on the other hand, there are people out there who are very narrow-minded and unethical. That's true too. It's true in pharmaceuticals. It's true in government. It's true in doctors. It's true in, you name it. It's true in artists. It's true in all of us. This is not new. Back to your other question though, and that was about older people. And the answer is it will work less well on older people than in young people, as you might expect. And that's been true of almost all vaccines with varying degrees of difference. But again, largely it depends on what I've talked about, which is the cell changes in aging T cells and other parts of the immune system. Okay, good. So, for example, it may be that the Pfizer vaccine is 90% effective in a 20-year-old and only 83% effective in a 70-year-old. Those aren't real figures. I just, that's the sort of thing that would be perfectly reasonable. Or it may be 97% effective in a 20-year-old. There's going to be some difference. Okay,
for the moment, but it can be improved when the technology, the platform that you were mentioning at the beginning of this discussion can become practical, and when aging can be treated.
That remains to be seen, but yes, I think so.
So there won't be any problem for vaccine or any other.
Oh, there'll always be problems, right? Okay. And even with the vaccines, you can improve it somewhat. So for example, most people that get a flu shot once a year, I tend to give myself 2, sometimes 3 during the flu season, because the last thing I want to do is come down with it. You can improve it by giving it serially. And different vaccines have different efficacy rates depending on how often you give it. For example, the Johnson & Johnson is a one-shot vaccine. The Pfizer, I forget the exact number you have to give it, but most of the other current vaccines, Moderna and so on, tend to be more than one shot. But what happens if you give beyond that? Well, you may get more reactions too, but you may also get more efficacy. So it gets complicated. If it's risk-free,
and you can.
Nothing's risk-free.
Yeah, sure. Yes.
But it's a balanced risk.
Yes.
You can have you can respond to the measles vaccine, which is about 97% effective. And you don't want to die of the measles or have your children die of the measles, but it's not that there's never been a reaction to the measles vaccine. The same is true of tetanus. The same is true of smallpox vaccination. Again, the same is true of the rabies vaccination. I mean, these are classic historical examples, and they saved thousands, millions of lives in some cases. But that doesn't mean there weren't some people who suffered as a result as well.
Sure. Like the medications, yeah. You also said something interesting about the, I think, mismanagement of the resources. Yes, I ask you that, is there enough pressure from patients' organizations? Is there enough investment? And you said there is enough investment and enough pressure. The problem is that the management is not good. Yeah, and I asked, can you explain how it can become better or why it is not good? Some people, they say that this is a problem of leadership. Some of my colleagues, they think that this is a problem related to leadership or healthcare management. So I personally, I do not like health economics, the subjects that they are treating. The results most of the time are not efficient. I read the works of my colleagues, I tell myself such a waste of time, 1, 2 years, 3 years, just to have these results that are not sufficient, or they do not prove anything, or they do not show anything. So health economics, I think this is something very old fashioned, it is not really, it's not something useful today. in my view. This is my personal view.
Let me give you an historical perspective or an historical example. Right now, most countries at some level in the government or the healthcare systems are concerned about the long-term cost, for example, of Alzheimer's disease, because taking care of an Alzheimer's patient in the last year or two of life can be extraordinarily expensive and a big drain on healthcare system in any country. But if you look back historically, much the same was true of the polio epidemic in 1950. There were people who were predicting that many countries, among them the UK, the US, Canada, would be medically bankrupt by the year 2000 because of the cost of treating polio, which in 1950 involved iron lungs, full-time nursing care, rehabilitation, braces, and so on. And yet, polio is an infinitesimally small part of the healthcare budget globally. In fact, it now costs about 10 cents a person to prevent polio. And I think that that's the kind of thing that we can do with regard to many age-related diseases like Alzheimer's. But if in 1950 I had put the entire government organization and all big pharmaceutical firms in charge of perfecting iron lungs, that would be mismanagement. It would be a waste of resources. Now, mind you, if in 1950 I had a daughter who had polio, I want an iron lung. But I would prefer if I had a Salk vaccine and she didn't get polio. That's where we are now. We have big pharmaceutical companies putting large resources. For example, Biogen Eisai, as of middle of last year, had put some, that is of 2019, had put about $750 million into their work on Alzheimer's disease. But as we found out now a few days ago, or 4 days ago, the FDA is probably going to turn down their bid for the anakinumab because it's really not effective. And yet they put a lot of resources in it. And I think that whatever you think of the anakinumab results or a lot of other research, simply putting more money into something is not by itself enough. The question is, are you putting money into something efficiently? If I just throw it down the drain, that's not efficient. If I can actually come up with a Salk vaccine or a way of treating and preventing age-related diseases, that's another thing. So it's not a matter of how much money we put in or how many patient groups are pushing on it. The question is, are we applying the money in the right place, and are the patient groups pushing for the right thing rather than pushing for better and better iron lungs? I don't see the value in perfecting the iron lung when we can perfect an actual treatment.
Yeah, that's it. I have a friend who is working, I have several friends who are working on drug repurposing, repositioning for COVID and beyond COVID. They said that they have a lot of difficulties with regulation, with regulatory affairs, and they cannot, they cannot accelerate the process. It's not only for COVID treatment, even for for those diseases that patients really need something new, because it's not cost effective or because the healthcare system cannot reimburse it, the patients should wait and wait years, even years. And it is very difficult for patients, that's why I do not like health economics, because these are health economists who decide, within the government, which medications can be reimbursed. Is it cost effective or not? At least I know the French system a little. It is very complex. How do they decide about the innovativeness? How do they evaluate the innovativeness of a new treatment? I do not agree with the system that has been designed to decide about the innovativeness. I think it's missing. A lot of information is missing from that, but nobody has ever tried to improve it since they are using it. So about the system that you have, you're working about to cure aging, as I understood, is
the cure age-related disease. How's that?
Curing age-related diseases, yes. Is the regulatory system aware of the importance of this new achievement about this discovery? Are they helping you to accelerate the access to such cure?
Yes and no. Any organization. I am glad that I'm not in charge of any country's healthcare system, because whatever I did, I still wouldn't get it right. It is, I think, impossible to design a system that is perfect. It's like having a perfect justice system. There are going to be cases where people are punished who shouldn't, and people get free who shouldn't. That's sort of the nature of reality. I don't have to like it, and it doesn't mean I stop working. It simply means I have to understand that I can't achieve perfection. And the same is true with regard to systems, whether they're government systems or other academic systems that support or encourage research and innovation. By their very nature, they cannot get it right. That doesn't mean they shouldn't try. It doesn't mean we can't improve them. But neither the French system or the British system or the Canadian system or the Chinese system, the US system are perfect. None of them are, nor could I necessarily improve them. Again, doesn't mean we shouldn't try, but we're never going to have a system where everybody agrees we've done it. It's just not going to happen. And that's true of innovation. It's true of the kind of thing I'm talking about with age-related diseases. Now, part of the problem is that people don't, as I say, recognize what aging really is and the role it plays in age-related diseases. And that's simply a fact of history. And there's not much I can do except keep pushing till we get there and can prove our point. But there are intrinsic problems sometimes in some of these systems. Example, if I want to apply for a grant in the US and I've never done it before, I'm often, you're lost. You're not sure how to begin it. And if you've got a startup company, you're particularly confused by this because of the government regulations, but they're there for a purpose, to keep people from applying for things they don't need or wasting government money. But it's very difficult when you're a startup to do that. And some of these assume that you already understand this, but it's only the big companies, whether it's big pharma or whether it's a big academic center. The Sorbonne, for example, probably has people who full-time are involved with this sort of discussion with the government and granting system and can find those sources. Whereas if I have a brand new innovative company outside of Paris, I don't know how to do that. And it takes me time, money, resources I don't have to try to get the money that somebody in the government might like to give to me as an innovative company. But in fact, there are already sort of built-in problems with doing that. And again, it's sort of the nature of the system. You'd like to prevent that. Here's an example. If in the US, I want to have a small business grant from the National Institutes of Health, one of the requirements is that when I do the actual work, the initial animal studies, for example, I have to do it myself. I can't simply contract it out. Well, one, more and more companies these days, particularly startup companies, rather than building a building, they're contracting out their work. Well, the grant won't go for that. And over the past 12 months, as COVID has hit, more and more people want to deal with things at a distance like that, rather than have a big group of people brought together to do this. So for a number of reasons, you find that more and more companies are actually contracting things out, and yet that's not made allowance for in government granting rules. But it may take you a week and several $1,000s to find that out because you're not used to these granting rules. So that's the sort of thing we could and should change, but we'll never get it right. We could just tweak it a bit and improve it somewhat.
Yes. And do you think that curing the diseases that are related to age, is it something that can be accessible, affordable for everybody, or it can be only accessible for very rich people? Is it very costly?
Well, right now, if you decided to make it yourself, it would be very costly. But in the long run, absolutely not. My current estimate, and it's just an estimate, is that if in a couple of years, if I wanted to be able to cure your Alzheimer's disease, my estimate is that it might cost $5,000. That compares to more than 20 times that for the cost of treating an Alzheimer's patient at last year of life in many countries. So what you're looking at is a savings. Now, that doesn't mean that I don't have $5,000 in my pocket. You probably don't. Most people don't. But that doesn't mean that you couldn't get it if you were trying to prevent your Alzheimer's and you've got 50, 60 years to get that together to prevent it. And that's only the initial, initial part of this. I think we can do a lot better for a lot of other diseases as well and end up lowering those costs. When you have more and more patient populations involved, the prices tend to go down. Yes, I think we can make this something that, like the case of polio, won't be 10 cents a head, but what you'll find is that the cost of healthcare will fall, not rise. If I look back historically, I find that whenever people talk about the increasing cost of healthcare, they're talking about technical incremental advances. For example, robotic surgery. For example, a fourth generation antibiotic. For example, the latest coronary artery bypass graft surgery. Those kind of technical advances are expensive and they have marginal improvement in healthcare. But the single greatest improvement in healthcare in history was the advent of the microbial theory, because it allowed for things like washing hands when you deliver babies, which cut the maternal death rate and neonatal death rate to something much, much smaller than it ever was before. Saved lives, and yet soap and things like that are remarkably cheap. So what I'm saying is that the most important things that ever happened in history in terms of improving healthcare and cutting costs have been conceptual revolutions. The idea that microbes cause disease. That had a huge impact. You know, the first antibiotics, the first vaccinations, the rabies vaccination that Louis Pasteur came up with, all of these things actually lowered the cost of healthcare. Didn't raise it, lowered it. And I think we're about to do the same for age-related diseases. Most age-related diseases currently are treated with technical advances, and they are extraordinarily expensive compared to the benefit you get out of them. I think we're about to turn that on its head. And in the next 10 or 20 years, we can end up lowering the global cost of healthcare while improving human quality of life.
Okay, thank you very much. I think that I have asked my main questions about COVID, about aging, and about the technology on which you are working. If you want to add anything about the pandemic of COVID, if you want, or about the future vaccine, we will be glad to hear about it. Or if
no, except to make the same point that I think many other people have remarked, which is that this is not the last global pandemic.
Okay, and when it will be the second, we should be prepared.
As they would say in Arabic, inshallah.
No, I hope no. I hope that not, at least we have some years between the second and, this one.
Mm-hmm.
So, because it's very difficult. I do not know how you are living it there, this pandemic, but it's very difficult here in France.
Mm-hmm. No, and it will be. And I think you're right, though, that we will at least get incrementally better at this for the next one. We have been in some ways very lucky. The fatality rate for COVID has been nowhere near the fatality rate for Ebola, for example, and it could have been. So yes, it's let's hope the next one doesn't have a higher fatality rate and a better ratio of spread. COVID doesn't spread very quickly, person to person, compared to some microbes we know. And as I say, it's not as fatal as some microbes we know. Rabies, is another good example. If this has a fatality of rabies and spread the way influenza did, we would have wiped out most of the world's population by now. So we've been lucky, and hopefully it's been a lesson to us.
Yes, let's hope so. So thank you very much for this interview. And I do not know if you can send me the recording of the interview later by email.
I'll send you the link to it. My pleasure.
Thank you very much. Thank you very much. It was a pleasure discussing with you. Thank you for your time.
Thank you. My pleasure.
Thank you. Thank you. Bye-bye.